Hello, my name is Dr. Bruce Williams. I am a veterinary pathologist at the Armed Forces Institute of Pathology and also the president of the C.L. Davis Foundation. And it's my pleasure this afternoon to talk to you about cytologic descriptive techniques. As I generally do before every lecture, I do want to thank people who have enabled me to put this material together. For this particular presentation, special thanks have to go to Dr. Donald Mutin, who provided the original lecture and was part of our descriptive veterinary pathology course for many years. Over the years, we've added a number of new case presentations and additional slides to his original lecture, and additional material has been provided by Dr. Sarah Hale of Covance Laboratories and Dr. Ed Stevens of the Armed Forces Institute of Pathology. With that, let's talk for a couple of hours about cytologic descriptive techniques. We'll go to the first slide. And the cytology certainly has a number of advantages. Now, I am trained as a histopathologist. And for many years, most of what I did was traditional histopathology. However, in the last decade, I've seen a tremendous rise in the number of cytologic submissions in addition to our traditional cases. Many of the cases that we get from our veterinary clinics throughout the military start out as cytologies, and based on those reports, the animals may go to surgery, whereas when I started 20 years ago, those clinics primarily performed surgery without the aid of cytologic diagnosis. The advantages of cytology as opposed to histopathology are listed here. These are rapidly performed tests in a matter of minutes. They're, as compared to surgery, quite inexpensive in terms of the time it takes, in terms of the equipment that it takes to perform a cytologic preparation, and obviously in terms of cost for anesthesia, etc. These are generally relatively non-invasive techniques, especially when we're talking about skin lumps, which is the majority of what we see. Certainly there are invasive techniques associated with cytology, such as ultrasound guided fine needle aspirates, which we do in some of the abdominal viscera. And today, even fine needle aspirates of brain lesions are being performed at specialty centers around the country. But the vast majority of the ones we see are non-invasive techniques. They do help establish a diagnosis or treatment plan. This is it's very much the same as a surgical biopsy. It's not meant to determine a definitive diagnosis, but certainly you can render the information necessary for a clinician to decide whether he wants to take this patient to surgery or not. For most skin tumors, anesthesia is not necessary. The pain associated with aspiration is simply the needle passing through the overlying skin, if there is such. Most tumors are not innervated, at least in terms of pain, so most animals do not resist this procedure much at all. And finally, the basic interpretation is performed in the clinic. I believe that a skilled clinician can make many of the diagnoses we're going to talk about today. This lecture is primarily intended for anatomic pathologists. As I said before, I'm not a clinical pathologist, but my job today requires examining quite a few cytologic specimens each day. I'd say today about 60, maybe 70% of what we see is cytology. My hope in giving this lecture is to give you some basic concepts, to look at some of the lesions that I believe that anatomic pathologists and pathology residents should be able to diagnose fairly easily. Is certainly not a substitute for a good background in cytology. Well, we looked at some of the advantages of cytology. Let's look at some of the limitations of cytology. Obviously, samples are not always representative of the lesion. Sometimes you sample the lesion in a in a bad spot. You may hit it in a large tumor, you may hit an area of necrosis. This is why generally when sampling, you try to take several samples. If you are introducing the needle into a lump, you go in from several different directions to try to make sure that you have some representative material. Obviously, some lesions do not exfoliate well. So you may be dealing with a spindle cell tumor or a sarcoma where you get very few cells and you're unable to make a diagnosis. So they're not always representative. Obviously, the architecture of the lesion can't be determined. Okay, so in cases of mammary tumors or in some types of lymphomas, without being able to look at the architecture of the lesion, it is difficult to come to a definitive diagnosis. Often, it is difficult to determine benign lesions from malignant lesions. Even in malignant lesions, you may be sampling an area where there are no obvious criteria for malignancy, and we'll go over all that later on in the presentation. You may sample an area which you don't have a lot of malignant cells, or you may be sampling a particular lesion that without histologic evaluation for invasion, you would not be able to identify malignancy. Endocrine tumors do not generally exhibit cellular features of malignancy, so that is one that cytology can be somewhat tricky. And finally, the skill and experience of cytologists vary widely, from residents to anatomic pathologists reading cytology to a skilled clinical pathologist with many years of experience. So all of these may impact on the specificity as well as the sophistication of your cytologic diagnoses. There are some preparations that cytology may actually be more appropriate than histopathology and more specific. Mast cell tumors, I believe that the stains that are often used in cytology can more readily disclose granules in certain tumors than what we see traditionally in histopathology. In lymph nodes, they're generally more sensitive and more rapid. It is difficult to definitively identify a type of lymphoma. It is more difficult to, without looking at architecture. But cytology is an excellent approach for the initial diagnosis of lymph nodes and the characterization of reactive nodes versus lymphoma. Obviously, when we're looking at bone marrow, cytology is superior. We do not have the distortion that we see with histologic bone marrow preparations, especially when decalcification is involved. You're able to spread the cells out and get a better appreciation for the variety and distribution of various types of immature forms, which we just don't get with histologic preparations. When we're dealing with, obviously, any type of fluid, cytology, especially if you have the ability to spin them down, is going to be very appropriate. Although in some cases, especially in human medicine, densely cellular fluids may be prepared as a histo preparation via the use of tissue blocks. Infectious agents, vaginal cytology, ultrasonography, all of these are probably more appropriate for cytology than histopathology. But let's look at a couple of reasons that histopathology is better. Histopathology is still considered the gold standard for tumor diagnosis. You do have the ability to look at architecture, especially in infiltrative neoplasms, where invasiveness is the primary characteristic of malignancy, such as thyroid carcinomas. Histopathology is going to be more appropriate. In terms of tumor grading, whereas mast cell tumors are easily diagnosed in cytology, it does not allow us to apply the tumor grading systems that have been used in the past and continue to be modified today. Histochemistry and immunohistochemistry are certainly more common in histopathology. But one thing I would like you to know is that you can pretty much do those tests today on cytologic preparation as long as you have a good technician in your laboratory. Well, these are a couple of the things that we're going to go over today in terms of what I believe that a good anatomic pathologist can diagnose on cytology. We're going to look at a number of types of inflammation, including septic, and where you see bacteria, non-septic, eosinophilic granulomatous or pyogranulomatous inflammation, and some of the organisms that you can diagnose on cytology. Generally, all of the fungal organisms, or dimorphic yeasts, other fungi, and some protozoan forms. And here are a couple of non-inflammatory, non-neoplastic lesions that you may be called on occasionally to diagnose via cytology, including hematoma, epidermal cysts, and sialoceles. And we'll look at the characteristics of each of those as well. In terms of neoplasms, the following neoplasms should be able to be diagnosed by cytology. Mostly round cell tumors are very characteristic. As we said before, some of these need to be staged, which we can't do on cytology. But the diagnosis of lymphomas and histiocytomas, plasma cell tumors, DVTs, and mast cells, these are all very doable by cytology. And we'll also look at characteristics of epithelial tumors, mesenchymal tumors, and of course, melanoma. So this is what we're going to look at over the next several hours. I would like to give you some general concepts and rules that will help you with these types of diagnosis. And we're going to finish the lecture with a number of case presentations. Now, how do we approach a particular slide? Well, at the AFIP, our residents are taught there's a certain way that we start our morphologic descriptions of cytologies. And we always start by assessing the quality of the slide as well as the cellularity. And when we talk about quality of slide, it has a lot to do with the slide preparation, the staining of the slide, the amount of cells which are traumatized or destroyed. Okay, because you can have a slide with a large number of cells, but if you apply too much pressure during the making of the slide, they may all be rendered broken and useless. And we look at cellularity. Okay, and cellularity is very important because you can't make a diagnosis on a slide which has too few cells. Okay, the term paucicellular is something that unfortunately I use way too often. Okay, and a paucicellular slide is one with too few cells to make a diagnosis. Cellularity can be broken down into adequate cellularity, paucicellular or hypocellular smears, or hypercellular smears. Okay, and hypocellular smears obviously are not going to give you enough information to make a diagnosis. Hypercellular smears, which you often see when you get bloody taps, may give you a preparation that is too thick to evaluate. Here are a couple of different types of smears in terms of cellularity. Okay, the first slide at the top may be paucicellular. I'm going to find it very difficult to make a diagnosis. Obviously, we have a number of spindle cells here, but is this a tumor, or could this be fibrous connective tissue or granulation tissue? If you only have a couple of cells to look at, I would strongly encourage you to state that up front and to qualify the rest of the information that you provide by the fact we only have a few cells to look at. Okay. On the other hand, in the bottom left-hand quarter, we have a smear that is, adequately cellular. We can easily tell that they are spindle cells. There is some variation in size, and we can get a lot of information, even a binucleated cell or two in this preparation. So a adequate number of cells gives you a useful working diagnosis. Finally, in the bottom right-hand side, we have a hypercellular smear from a lymph node, which can be very difficult to interpret because of the number of cells. They're piled on top of each other. It's a very thick preparation, and it's difficult to get useful information from this type of smear. A cytologist will often be called on to look at various types of preparations, including the most common in our practice at the A5Ps are fine needle aspirates. Okay, you can get touch or impression preparations, and I will say this now, I will say it again, that there is usually very little useful information that can be gained by pressing a glass slide against an ulcerated neoplasm. A lot of what you're going to get is debris and inflammatory cells. When I am talking about touch or impression preparations, I'm talking about those preparations that are taken at surgery and at necropsy. When a lump is removed, it is bisected, the blood is blotted off, and from that bisected surface you can make an excellent impression or touch prep, which will rapidly give you a diagnosis, even before the tissue is put in formalin. Might not be a definitive diagnosis, but gives you a place to start, or the clinician a place to start putting together his treatment plan. Scrapings can be excellent in certain situations. Tumors that exfoliate very poorly, such as sarcomas or any type of mesenchymal tumor, tend to do much better with scrapings, because you can actually take some of that tissue off and spread it on a slide. Fungal cytology is best done with scrapings. And then cytospins. When you're looking at effusions, where you have fluid that builds up in a cavity, you may have several hundred milliliters, and the cells will be spread widely. But if you can take that preparation and spin it down and concentrate those cells, you're much more likely to get a useful diagnosis. Okay, and these are a couple of preparations that are the top right-hand corner is a cytospin preparation, okay, from the urinary bladder of a dog. And we get a lot of neutrophils, but we also concentrate those neoplastic cells. And in the bottom center, we're looking at a touch impression from a bisected lymph node, which gives us an adequate cellular preparation with just a little bit of blood. A lot of times when we get fine needle aspirates, especially of lumps from the skin, we get what are known as squirt preps. There's only a little bit of material that comes out of the needle, and the material is squirted on the slide and allowed to air dry. While these are not often optimal preparations, we do like to have a nice, regular smear. You can actually get a lot of good information, whereas I used to look at these with some sort of disdain. I've made enough diagnoses on squirt preps over the years that as long as it's well done, I would rather look at a squirt prep than have someone try to spread these out, because it tends to crush the cells, whereas in the middle of some of these dots you can see some diagnostic features. Impression smears, okay, or imprints, as we talked before, generally are best done with freshly cut tissue which has been bisected. Okay, you can often, with epithelial tumors, and especially round cell tumors, get adequately cellular smears to render a good diagnosis. Okay, and if you look at the tissue in the bottom, I'll blow that up, the preparation in the bottom. Okay, we're going to use 2 slides for most, and you never know what is the most appropriate level of pressure to get the most optimal yield of cells. With some tissues you have to press very hard, some very gentle pressure will give you appropriate cells. What I generally recommend is to take the piece of tissue and start on the end of one slide and just touch it just as gently as you can, and then go across the 2 slides, pressing down harder and harder each time. And with 8 different touch imprints, you will probably find at least one of them is going to give you optimal cytology for diagnosis. As we said before, scrapings are very useful in certain events, especially with mesenchymal tumors, because they tend to exfoliate poorly. They're often trapped within matrix, and an imprint often will yield little to no useful cells. Okay, I will reiterate that taking a slide and pushing it against an ulcerated tumor rarely, if ever, yields any diagnostic information. Simply gives you debris and inflammatory cells. There are a number of stains for cytology, and your laboratory should be equipped with all of these. Okay, the Reitz-Romanowski stains, such as Diff-Quick, are an excellent general purpose stain which will give you good information on most of your cytologies. Okay, realize that the biggest problem that we have in our laboratory with the use of Diff-Quick or like stains are 2. One is that they tend to over time lose their effectiveness. Okay, the more stains you put in them, the more times you use them, they will stain more and more lightly. Okay, you also will have, because there are no preservatives, you can have bacterial growth within them. So these stains should be dumped out and fresh materials put in at least a weekly basis. Okay, occasionally they don't stain mast cell granules, especially in horses and cats, but for the most part they do a very good job. The second thing that I would recommend in your laboratory would be a gram stain, because a lot of the cytologies that you will generate will be from inflammatory lesions. And if the cytology has a lot of neutrophils, one of the first things I'm going to look for is bacteria, thinking I may be dealing with a septic infiltrate. And it's very nice to be able to put a gram stain on some of these. The third is new methylene blue. And I think if you are looking at a cytology where you want to inspect the nucleus very well, okay, look at chromatin patterns and nucleoli. New methylene blue brings this out. Obviously, if you are doing blood smears, which we're really not going to talk about, you want to look for evidence of polychromasia. New methylene blue will be helpful in that aspect as well. When we approach the examination of cytology, it is important that the first thing we do is to scan the entire slide on low power. I generally recommend 4x because obviously this is going to help you identify the areas of the slide which have optimal cellularity. And on paucicellular slides, you may only have cells in one small area of the slide. So first thing we want to do is look at the entire slide. Okay, this will also be able to tell you whether it is stained adequately or whether we may have to go back and restain some areas. Okay. After that, then you can go to your areas of adequate cellularity and look at those at higher magnifications, generally 40x. Okay, one of the things that especially practitioners, but also people who are not familiar with cytology like to do is they like to put oil all over the slide. And a good cytologist rarely, if ever, uses oil. Okay, oil immersion brings everything very close and gives everything an added feel of malignancy. I would love to take all the 100x objectives off of my resonance scopes. As a matter of fact, I would like to take 40x objectives off of a lot of them because, you don't need to go down to highest magnification. And of course, we're going to look at this, but cover slip your cytologies. Generally, practitioners don't. A lot of times when we get them, the slides are just covered with oil. There's no cover slip. But you will be amazed, I'll show you in a moment, what cover slipping your slide will do. Obviously, you want to wait until the stain is dry. Okay, which image do you prefer? Okay. Now, if you look at a slide with oil, it will look very much like the one on the left. If you look at high dry, it will look sort of hazy, like the one on the right. Okay? Actually, that was a trick question. Neither have oil, and hopefully you recognize that the cell sizes are the same between the left and the right picture. So I was pulling your leg a little bit. This is the difference that is seen when you cover slip a slide and when you don't. Okay, it's the same slide. Okay, the picture on the right was taken without a cover slip. The picture on the left was taken with a cover slip. Remember that the objectives of your microscope are calibrated for cover slip slides. And so it has trouble focusing without that little tiny piece of glass or plastic between the cells and the objective itself. So always cover slip your slides after they are dried. A little bit of glue, a little bit of cover slip. You will be very happy with your results. A lot of the things that you will see on your cytologic preparations are artifacts or other contaminants, and I would not want you to misinterpret this. All of these can be misinterpreted as something else. So I want to quickly go through some of the very common contaminants and other artifacts so you don't make a mistake. And this is actually, right here, this is talc. It's commonly used in surgical gloves, and when it is birefringent powder, and it's absolutely gorgeous when you polarize it. Before we look at contaminants, we'll look at artifacts. And unfortunately, this is occasionally the kind of slides that you see, where you have pools of blood and you have these skid marks, and someone has scraped it across. Okay, and it can be even worse if the practitioner has spilled oil all over, or put oil to look at it, and then decided they didn't want to send it in that way, so they go to wipe the oil. And what happens is they will wipe off the slide, and they wipe it clear of cells just as well. So this is something that you really don't want to have show up on your desk. We've looked at the talcum powder in the center. Some of the other things that you will see, one of the most common contaminants, as we see in the upper right-hand corner, are what's known as squames, also known as keratin debris, or keratin bars, or even rolled keratinocytes. I've heard a number of names for this. And these are simply keratinocytes, which probably come from the hands of the person who is preparing the slide. Because when you handle the slides, a little bit of keratin will come off of your fingers. And this is what it generally looks like. This is not to be interpreted as anything. In the upper right-hand corner, stain precipitate. If you're not changing your stain on a regular basis, you will develop stain precipitate, and a non-diagnostic feature. In the bottom right-hand corner, something that we see, this sort of granular purple material. Notice I didn't say basophilic, because these stains don't use hematoxylin or eosin. So this purple material is something that we occasionally see on ultrasound guided biopsies, and that is the ultrasound gel, which you get it on your fingers as you're doing the ultrasound in just a little bit, and then if you don't wash your hands carefully or take off your gloves when you're preparing the cytology, you may smear it on the slide. And then something else, and we'll look at this again, is the bottom left-hand corner. We have smeared nuclear debris, what we call I'm sorry, I'm blanking on that, but you know, when you press too hard, cells will rupture, and we call them nuclear streaming. I call it streaking cells. But one of the things that's very difficult is to train yourself not to look at those cells at all. They are not diagnostic. Here's a one with several different types of artifacts. Now, one of the things that will ruin your cytologies quite readily is exposing them to formalin fumes. It is a very bad idea to package aspirates, air-dried aspirates, in with necropsy material from the animals, because generally it develops a greenish blue. They don't stain properly, and they don't take up stain very well. So everything sort of has a greenish blue haze to it. Okay. Another way that you can ruin a good smear is not to dry the stain before you, or the preparation before you start to stain it. Make sure that your smears are adequately dried. You can put them on a drying rack, or you could even use a hair dryer on low setting if you're really in a hurry. Okay, but you can't properly stain a wet smear. And this is what those cells are exposed to formalin look like. You can't get a look at them. They're sort of bluish green and very hazy. You can send this slide to IDEX. You can send it to Antec. Just don't send it to me. What we're looking at here is let's ignore the staining right now, but this is one that was made by somebody maybe who spent too much time in the gym. Look how hard they have pressed. They have ruptured all the cells. What we're seeing is the streaming of the nucleus, and all these small bubbles are lipid from ruptured membranes. There's not a diagnostic cell in there. And a lot of times the practitioner, this may be the only smear they have, and it's going to be very difficult to get the animal back, and they want you to make a diagnosis. And if I can convince you of one thing during this entire lecture, this will be the one. Never make a diagnosis on a ruptured cell. It doesn't matter if it's the only cell in there, or you think you can see something. If the cell is ruptured, you should avoid making any diagnoses. What I would send back to the practitioner on a slide like this, it is simply a non-diagnostic specimen that all of the cells were ruptured, and useful diagnostic information could not be obtained. Never make a diagnosis that you are not comfortable with, and never make a diagnosis under pressure. And this is one that you could not pay me enough to try and make a diagnosis from. Here is a preparation that was poorly stained. Okay, this is a lymph node aspirate. And a lot of times these will be stained by the practitioner and sent to you stained. And this is one that needs to go back and be decolorized with alcohol and restained. Okay, I cannot make a diagnosis. Even though I believe that there are some large nucleoli, I would certainly not want to make a diagnosis on this type of preparation. As we said before, DivQuick will lose its potency over time. So if your stains are light, the particular one in the center here, it stained the red blood cells very well, but all of your white blood cells are not stained at all. Now you have a couple of choices here. You can go back and decolorize it and start all over again, or you could simply just take it back and dip it into the polychrome stain, which should fix the problems. There's really no need to go back and put it back in the red stain. So you just dip it a couple more times. If your stains are coming out too light, dip it a couple more times. Leave it in the stain for a longer time. You can always go back and decolorize it again. If it overstains, you go back and decolorize it in alcohol. Well, those are just some basic concepts about stains and staining and when to interpret and when not to interpret. And remember, all of that will be reflected in that first sentence, which is usually quite simple, and will say something like, this is an adequately stained, adequately cellular fine needle aspirate. And that sums it all up. Now let's start taking a look at how we're going to interpret these. And these are going to be, for the most part, we're going to assume at this point that these are adequately stained, adequately cellular preparation. And a lot of times you will get a history of there is a lump on the side of the dog. Now the first question that you ask when you're evaluating, not that you ask the practitioner or the owner, but first question you need to ask yourself when you first start looking at these preparations is a simple one. Are there neutrophils or not? If there are neutrophils, you're almost always dealing with an inflammatory lesion. There is one particular neoplasm that generates a lot of neutrophils, and that we'll see later on, that's a squamous cell carcinoma. The reason it does that is it produces keratin. The body does not like keratin. And if it's not outside of the body, as it is in fingernails and hair and hooves, it's inside the body, it generates a profound neutrophilic response. So anything that liberates keratin into tissue, like a squamous cell carcinoma, a ruptured hair follicle, anytime you have hair within the body, or keratin, you're going to get neutrophils. But the vast majority of neoplasms, you see no neutrophils. Okay, if you don't see any neutrophils, then you're dealing either with a neoplasm or some type of cyst which is not previously ruptured. So once you've established that there are neutrophils, the next question is, do neutrophils predominate? If a neutrophil is the predominant cell type in an aspirate or a cytologic prep, you are dealing with inflammation. If over 90% of the cells are neutrophils, you're dealing with active suppurative inflammation. Okay? Now things, obviously in abscess, you're going to have large numbers, almost exclusively neutrophils. And a lot of them will be degenerate. They will rupture on making the smear. Okay, there are a number of times when neutrophils will predominate. They will be admixed with macrophages. This suggests a bit of chronicity, that this inflammation has been going on for a while. The body is sending in macrophages to assist in the cleanup. And you will see this with bacterial infections, with fungal infections, and with foreign bodies. Well, if you can remember this algorithm and you understand it, you can probably turn the DVD off. What I would like to do is essentially take you through this for the rest of the lecture with a review at the end and give you some hints about the diagnoses of all of these various types of inflammation, non-neoplastic, non-inflammatory lesions, and finally neoplasms. So we're going to start with the inflammatory lesions and the question, do neutrophils predominate? Okay, if they predominate, look at the proportion of neutrophils, and if there's a mix, you want to consider things we talked about: foreign bodies, long-standing bacterial infections, fungal infections, some parasites. Sometimes if you have eosinophils, you might want to think about hypersensitivity and some idiopathic conditions. When we look at infectious agents, I believe that size and location are key. Luckily, they do tend to vary in size. And because we don't generally use micrometers or stage micrometers when measuring these agents, I like to use things that are almost always present in the smears and judge their size against that. Organisms that are smaller than a red blood cell are listed on the left-hand side of this slide. They include several protozoans and fungal agents. Okay? If they are bigger than a neutrophil, you're dealing with some of the larger fungal agents here and some larger parasites. Here's our first case study. We're looking at an adult cat which has a swelling over the bridge of the nose, and the clinician opted to do a fine needle aspirate. Now, as a pathologist, I have my own list of possibilities, even without looking at the aspirate, what I might see on the nose of this predominantly white-faced cat. So what's your first question when looking at that cytology? Well, we've already done that. That is going to be, are there neutrophils? And this is what that particular slide looked like. So yes, there are neutrophils. Do they predominate? Well, what I see when I look at that slide is I see a number of neutrophils. I also see macrophages. They're larger with foamy cytoplasm, and within those cells I see other structures which are surrounded by a prominent capsule. The bottom right-hand corner, you can get a better look at some of these round fungal yeasts which have been engulfed by a macrophage. And there are some neutrophils around them. They are variably sized. If we were lucky, we might see some budding. But one thing that stands out is the presence of a capsule around them. The capsule does not stain. Well, this is a case of Cryptococcus neoformans. It was certainly on my list when I thought about lesions of the nose of cats. Another thing I thought about would be a squamous cell carcinoma, because the cat had a predominantly white face. But when you see this and you see the macrophages and neutrophils, and then these non-staining, or these yeasts with non-staining capsules, Cryptococcus obviously is a good possibility. Well, here we're looking at a 6-year-old dog which had an ulcer and a draining tract on the foot and had labored breathing. Thoracic radiograph looked like this, and we decided to aspirate the foot lesion and do a transtracheal wash. And the first question when we look at the aspirate of the foot lesion is, are there neutrophils? And this is not a great prep, but we can see that there are a number of neutrophils scattered throughout, but they don't predominate. They are admixed with some larger cells, which are macrophages, which contain budding yeasts. Look, almost all the yeasts in here are budding. remember we thought about our list of organisms that were smaller or larger than an erythrocyte. Okay, obviously, or a neutrophil. These organisms, if you compare at 20x, the size of these fungal yeasts, they are larger than a neutrophil. They are round, so we have to exclude histoplasma, and we have to include blastomycosis on our list. Okay, and in one area of the transtracheal wash, we saw multinucleated giant cells, which are not extremely common, but can be seen in fungal infections. Usually blastomycosis and histoplasmosis have a lot of inflammation, as does coccidiomycosis. Occasionally you'll have cases of cryptococcus in the lung or in other organs which have minimal inflammation due to the fact that they have these large capsules which make them very difficult to be engulfed by macrophages. And if they're primarily extracellular, you don't get the activation of macrophages and recruitment of other inflammation. So occasionally you will run into cases of cryptococcosis with minimal inflammation, both on cytology and on histopathology. Well, we did talk about histoplasmosis, something we see a little bit more commonly in cats, especially in the Ohio River and Mississippi River Valley areas, but you can see them anywhere. And I want you to take a look. We're looking at a macrophage, or on both sides, numerous macrophages, which are packed with small, round organisms. And I want you to compare the size of those individual organisms with the erythrocytes in the field, and they are smaller. The nucleus generally is eccentric, and the organisms are often surrounded by a small halo. The vast majority of these organisms tend to be intracytoplasmic within histiocytes. And on the left, a lovely picture of histoplasma in a cat, giving you a multifocal to coalescing pyogranulomatous pneumonia. The identification of fungal hyphae in cytologies is not a common diagnosis. Okay, and they often don't stain, so it makes them a little more difficult to identify. Okay, if they do stain, as we see in the two cytologies on the right, septations show up extremely nicely. The stain in the bottom right-hand corner was taken from a ulcerated area in the corner of, in the cornea of a horse. Just a wonderful stain. That's a once in a lifetime, and you can even see the fruiting body of this Aspergillus. Lovely, lovely picture taken by Don Mutin. The location of the aspirate or the impression smear is often very helpful in the diagnosis of fungal infections. Areas that are well aerated, including the nasal passages, okay, especially if there are osteolysis. This may be the result of fungal infection. Most fungi, to grow in hyphal structures, and especially to have those fruiting bodies, will require oxygen tension. But you can also see just regular hyphae, not the fruiting bodies, regular hyphae in a wide range of locations, including bone, stomach, skin, and the cornea of horses. Remember that horses live in an environment where fungus is omnipresent and very commonly will develop fungal keratitis, especially when they are being administered steroids or antibiotics. And this was a conjunctival scraping from a horse, and you can see the pale pink staining fungal hyphae, which has dichotomous branching at 45-degree angles, consistent with Aspergillus. Okay, we're looking at the aspirate of a cat. This cat had several ulcerated lesions on the pin of its ear, and the cervical lymph node on that side was enlarged. An aspirate shows numerous macrophages, which contain small amastogotes, both free and within the macrophage cytoplasm. I also see some other cell types. Okay, in the center, I see a plasma cell and probably a couple of neutrophils here. Certainly one plasma cell, which tells me this is a reactive lymph node. It's not enlarged because of neoplasia. We'll talk a little bit more about lymph nodes later on. But these cells are just jam-packed with these small, round organisms. And if you look very closely, you will see that they are approximately the same size as histoplasma, but they don't have that eccentric nucleus. What they have are two little bits within them. And we are looking at leishmania. Leishmania has generally two dots. You have to look at fairly high magnification. You can just barely make them out at 40x. Okay, these are taken at 100x, and you can see that within the macrophage cytoplasm, these organisms have a nucleus, and then they have a kinetoplast, which is oriented perpendicularly to that nucleus. So this is leishmania, the same size as histoplasma, but does not have that kinetoplast. Okay, both of those can be present in large numbers. When you're dealing with leishmania, often the animal is in a part of the world where leishmania is prominent or has traveled from that part of the world. Just a couple of other things that might help in the identification of leishmania is that you often have a nice mix of inflammatory cells. There's usually a fair number of plasma cells and lymphocytes in the aspirate as well. You don't see one or two. Generally, they're very large. It's not something that is that difficult to, or a very large number. It's not that difficult to pick out. With a number of cases of histoplasma, which is a similar size, if you look at it histologically and apply a fungal stain, you may only see a couple in the whole smear, but when leishmania is there, they're usually there in very large numbers. Now this one is actually quite rare, and you may see it in animals, especially cats. You would think that you wouldn't see it very often. We don't see it that often in cats because they are the natural host, but sometimes you'll see it in kittens or immunosuppressed animals, and they can have a diffuse toxoplasmosis. They do get a very profound interstitial pneumonia, which is necrotizing, and with transtracheal washes, you can very rarely see these toxoplasma schizons. There's an intact one on the left, and the one that is on the right is ruptured. Notice how the macrophage is containing it. Also, there are a number of neutrophils in the field, and you can see the banana-shaped zooids with a nucleus, generally at the tail end of these. But this would be a very uncommon thing to see, and if you're lucky enough. Now, most ear swabs of dogs will have these commensal Malassezia yeasts within it. But when you see this many, you are likely dealing with a pathogenic problem. The cutoff is usually somewhere around 10 per high-powered field. If you're seeing 10 or more, and the animal does have clinical otitis or dermatitis, it may be the cause of a lesion. But just remember that it is a very common contaminant. You can see it in normal ears, normal skin, and do not associate the presence of low numbers of these with disease. To me, they look like bedroom slippers or footprints. A lot of people think they look like footprints. Transtracheal washes. This is a transtracheal wash from a horse. And one thing about horse eosinophils, they are bright, they jump out at you, and whenever you see this many eosinophils, especially with mast cells, you want to consider the possibility of hypersensitivity reactions. Okay, and in the horse, as a transtracheal wash, we would be considering allergic bronchitis or chronic obstructive pulmonary disease. Looking at eosinophilic inflammation, you will often see the occasional eosinophil floating around in many aspirates, especially if there is peripheral blood. And a lot of aspirates are bloody. A little bit of blood will get in there, and that is often a source of eosinophils in cytologic preparations. So we try to have a cutoff, and the cutoff is about 20%. If you have more than 20% of eosinophils in a particular cytology, then the diagnosis of eosinophilic inflammation is probably acceptable. Obviously, the same things that cause eosinophilia in anatomic pathology would cause the same in cytology. So we're looking at parasites, possible allergic or immune-mediated disease, certain neoplasms that release eosinophilopoietic factors, such as mast cell tumors or various lymphomas. And then there are a number of disorders of eosinophilic inflammation for which we really don't know the cause. Eosinophilic granuloma complex in cats, and horses with eosinophilic granulomas come to mind. Remember that not every eosinophil is going to have this bright orange granules like we see. The longer eosinophils sit in, before they're smeared, they sit in fluid, they will tend to become a little dingier. Okay, and the eosinophilic granules associated with cats tend to be sort of a really dingy rust or grayish brown. Okay, so they don't really jump out at you, but you do have to recognize the size of these granules to differentiate them from neutrophils. Okay, let's look at some of the non-inflammatory lesions that you may be called on to look at cytologically. If there are few or no neutrophils, we're looking at some form of cyst, which would include a seroma, epithelial or follicular cysts. Okay, if they are ruptured, not by the needle, but if they are previously ruptured, you may see neutrophils and macrophages, because that keratin liberation into the dermis will cause a pretty profound inflammatory response. Sialoceles, and generally these are in the area of the oral cavity, the head, or the cervical region. And hematomas. And hematomas and seromas can be interchangeable. Over time, hematomas will turn into seromas. So there is a little bit of overlap there. And then neoplasms. I want to start with the epidermal inclusion cysts. Okay? Sometimes these are very difficult to differentiate from keratin-producing neoplasms, such as trichoepitheliomas and trichofolliculomas and infundibular keratinizing acanthomas. Okay? But the general appearance of a keratinizing cyst or neoplasm is you get these flaky looking cornified epithelial cells, okay, which look like this. To me, they look like cornflakes, if you're familiar with that particular cereal. They're angular. It's difficult to pick up their nucleus. Usually they have none, or maybe it's a ghost. And what you're seeing is the keratin flakes from within here. But you're going to see the similar type of things with neoplasms of follicular origin. The other thing that helps to confirm a diagnosis of a keratin-producing cyst or neoplasm are these cholesterol refractile crystals. They're generally rhomboidal, and if you look, you will often see them. Okay, so you will see cholesterol crystals and these cornified, angular flakes of keratinized material. Okay, once again, sometimes, and these can be extremely ugly because you're looking for cells and all you see is this keratin, flaky keratin debris. But when you see this cholesterol crystal, then you can say. Now, at this point, it's very difficult to make more of a determination whether it's just a follicular cyst or it's actually a neoplasm. And usually our recommendations in our diagnosis letters would be that if clinically warranted, excision and submission for definitive diagnosis is appropriate. A lot of times you'll get bloody sticks, and oftentimes you'll get a history of a lump on a dog, and you'll be sent either a tube of this reddish fluid, or you may look at aspirates that have been made of this material. If you get the fluid, I strongly recommend, unless it's frank blood, which is up on the top left, that you spin it down, because what you're going to do is you are going to concentrate the cells, and it's the cells that will help you determine. And then you decant it. You can put a little bit more, like a drop or two of the serum back onto it. You may not have to, and you make your smears from that. Okay, classically, the presence of platelets within the aspirate suggests that there was contamination of blood during the aspiration. It was a bloody stick. Because if you're dealing with a lesion of any chronicity, the platelets will have clumped and have been degraded long before. Okay, if you see evidence of either erythrophagocytosis, or as those red blood cells sit within macrophages, they will be broken down and you will get hemosiderin. If you see that, you are generally looking at a hematoma. So what we're looking for, okay, in a hematoma, anything that has chronicity, you're going to look for mixed inflammation, and then the presence of phagocytized red blood cells, more here, and hemosiderin pigment. This is chronic. This is not a bloody stick. This is a hematoma. If you see platelets like this, then we're talking about a bloody tap or a bloody stick. Let's look at neoplasms. Neoplasms are also lumps. Okay? The first question that you ask yourself, do neutrophils predominate? They will not, with the single exception of squamous cell carcinoma. Generally, you'll see no neutrophils unless it's an ulcerated mass and it's been sampled through the area of ulceration or close to the area of ulceration. Then you generally see no neutrophils. Okay, When we first look at our neoplasms, we want to break them down into broad categories. The categories that we look at are essentially round cells, tumors, mesenchymal tumors, and epithelial tumors. And each of those have very characteristic appearances at low magnification. And realize that you often do not get to the absolute particular type of tumor when you're dealing with mesenchymal and epithelial neoplasms. Round cell tumors, as we'll see, can be a little more characteristic. And then there's another division. Generally, I consider them round cell tumors, but tumors that have granules. Okay? And those would be your mast cell tumors and your melanomas. The evaluation of these slides starts like every other one. First, you look at the quality and the cellularity of the aspirate. Then you want to make sure that there are no neutrophils. And then we're going to look at how the cells are arranged. Are they individualized? Are they in groups? Okay? We like to look at the cell shape, the nuclear shape, how the cells vary, including, the amount of cytoplasm, the size of the nucleus, and follow that with the presence or absence of any of the criteria of malignancy. All of these should be evaluated each time you look at a neoplasm. Now, we'll skip the part about do neutrophils predominate. These are going to be tumors, so they will not. And we will assume that all these are adequately cellular, well-stained preparations. What I want to look at right now is how the cells are arranged. Are they arranged in clumps, as we see in the bottom left-hand corner? Cells that come out in clumps are generally cells that are stuck to each other. And these are epithelial cells. Remember, epithelial cells have desmosomes, and they're sort of locked to each other. They're often locked to a basement membrane, and they come off as clusters or rafts of cells. When you're looking at mesenchymal neoplasms, as we see in the bottom right-hand corner, these cells are usually spindle-shaped, and they tend to exfoliate very poorly. So these will be the most paucicellular of the three. They're usually locked into a bit of matrix. Okay? They often are closely associated with each other. But look at the tails here. And there are a couple of things as we get into mesenchymal tumors that those tails will tell you. And finally, in the upper right-hand corner, here are cells that are individualized. There are a lot of them, but they're not attached to each other, and these are round cells. So we will talk about clusters of cells, which suggest epithelial. We'll talk about small aggregates of spindle-shaped cells, which implies mesenchymal, and individualized round cells. And here is a table which summarizes all of this information. The round cell neoplasms generally are 5 or 6 if you include melanoma. I was classically taught melanoma was a round cell tumor. But they all are fairly characteristic. And I think that it is well within the ken of most anatomic pathologists to be able to differentiate these. So we're going to look at lymphoma, plasma cell tumor, mast cell tumor, histiocytoma, and transmissible venereal tumors. When we look at mesenchymal cells or spindle cell tumors, I want to briefly mention that the differentiation between benign and malignant spindle cell tumors is often very difficult to make. Okay, things that you may be called on would be fibromas and fibrosarcomas, osteomas or osteosarcomas, hemangiomas or hemangiosarcomas. These are very difficult to differentiate cytologically. And one of the most common, maybe the most common spindle cell tumor in our particular practice, and those are peripheral nerve sheath tumors. Okay, some people, when they are on the leg, will call them hemangiopericytomas. And then a couple of the epithelial cell tumors that you should be able to diagnose would be sebaceous gland tumors and perianal neoplasms, basaloid epithelial cell tumors, transitional cell carcinomas of the bladder, and some that are very difficult. Maybe the most difficult tumor to identify cytologically is mammary neoplasm. They tend to exfoliate very poorly. They often have a mixture of cells, including spindle cells as well as epithelial cells. And we just see very few. I think I may have seen 2 or 3 prostatic neoplasms cytologically in the last 5 years. And when you're dealing with cells with granules, it usually falls down to, in areas of tumor, mast cell tumors and melanomas. Well, I guess we'll start with melanomas. And just like, as we say in histopathology, they can have many, many different appearances. The cells can appear round, they can appear epithelial, they can be spindle. This is the great imposter. But the characteristic of melanomas or melanocytomas is the presence of black granules. As we said before, it can be very difficult. In the absence of definitive malignant criteria to differentiate malignant cells or malignant tumors from benign tumors on cytology, we cannot assess invasiveness. And so a lot of times we will send out a diagnosis of melanocytic neoplasm and recommend excision. In our diagnosis letter, we will comment on a particular location. So if the aspirate came from the oral cavity or the digit, we will mention that melanomas in these areas have a higher rate of malignancy. Occasionally you will get some melanocytic neoplasms that obviously have evidence of malignancy, mitotic activity or mitotic features, large nuclei, marked anisokaryosis. So those are the easy ones, but the vast majority of these, it can be very difficult to say melanocytoma versus melanoma. And every once in a while, you will see some that will trick you and will have only a little bit of melanin. Very few cells have actual melanin, or may have some cells that have it and some don't. And I do want to remind you that the vast array of histochemical stains that you have at your disposal in the histopathology laboratory will also work on cytologic preparations. And this particular specimen on a touch imprint stained very nicely with the Fontana-Masson silver method, which highlights melanosomes, just like we would do in a complicated skin tumor on histopathology. Looking at epithelial tumors, generally these exfoliate in sheets or clusters. You can call them sheets, you can call them rafts, you can call them clusters, but the key is they're locked together by desmosomes. Okay, so they're going to come off many at a time, and you often can't see cell borders. And this one has come, we have rafts, we have a large cluster, and here you can actually see an acinus here as the cells. And you get the feeling here you might have another acinus. So a lot of times when the cells exfoliate well, you can get an inkling of the architecture of this neoplasm. Well, this is a mass on the prepuce of a dog, not a great preparation. But one question is, are there neutrophils? Yes, there are neutrophils. Okay, but I don't think anyone would ignore the presence of these very large, often multinucleated, lucent, blue cells. And here's a mitotic figure. As we said before, squamous cell carcinoma produces a lot of keratin, which within the body stimulates a profound neutrophilic response. So this is the one neoplasm that will always have a lot of neutrophilic inflammation associated with it. So much for the epithelial cell tumors. When we look at the round cell tumors, and we're going to look at 5 different types, cells are usually individualized, and they often come off in large numbers. Okay, they are, as we said, round cells. They don't generally spindle, although if you press hard enough on any type of cell, you can pull the cytoplasm and make it spindle. And that's sort of what's going on down here. Okay, this cell has a little bit of a tail, but it's just because that preparation was done, pretty roughly. They have distinct cell borders, and they are usually well differentiated. Here's a case presentation of a neoplasm on the lip of an 11-year-old retriever, and fine needle aspirate showed the cells on the right. And we have a neutrophil, but they certainly don't predominate. We have some blood, and maybe that's where the neutrophil came from. But the predominant cell is this large round cell. And some of them have these dark purple granules. Remember that mast cell tumors don't always stain properly with diff quick, but they usually do. And the other thing that I notice is some of these cells have these empty holes. And this is what we see with degranulated mast cells. And when they degranulate, and they can certainly degranulate during the making of this preparation, they tend to leave these holes behind because the membranes rupture, the granule material comes out, and there is a potential space there in the cytoplasm. And remember that you can have, if you're rough with your preparations, you can end up with a preparation where you have all of these granules scattered in the extracellular space. But this is a mast cell tumor. Now, if I asked you to tell me whether this was grade 1, grade 2, or grade 3, you wouldn't be able to do it. Because usually that classification incorporated level of differentiation and level of infiltration, which we can't see on a cytology. The most recent classification of mast cell tumors also requires you to look at mitotic rate and anisokaryosis level of differentiation, and you also can't do that. So great for identifying mast cell tumors, but poor for grading them. Take a look at all of these. This is sort of variability of mast cell staining. Some stain very well, some stain, as we see, very poorly. But the reason that this stained very poorly was that these mast cells were in the urine, sediment of a dog. And the fact that they stained at all was basically the result of using right stain on that. Lymphoma. We get lots of lymph node aspirates, often from the cervical lymph nodes in older dogs, which can be a real problem because older dogs often have bad teeth, etc. And the main question that we ask when we look at lymph nodes is, are they reactive or neoplastic? Because a lot of times they'll simply be draining an area of inflammation. So essentially, you have to assess. The first thing that I do when I look at a slide of lymphoma is I look for the presence of blood. If you get a slide in which, it's obviously taken from a large lymph node and there's no blood, okay, the normal aspirated lymph node will have a little bit of blood in it. If the cells are crammed in there so tight that there's no blood, okay, you have to think strongly about the possible lymphoma at that point. The next thing to look at would be the range of cells. If it's a mixture of lymphocytes, lymphoblasts, plasma cells, and there's the occasional neutrophil, you're probably dealing with a reactive node. Lymphomas aren't replete with plasma cells. And then we look at the numbers of lymphoblasts versus lymphocytes. If our cutoff at AFIP is approximately 40%, if 40% of cells are lymphoblasts, to us that is enough to make a diagnosis of lymphoma. Generally, mature lymphocytes are about the same size as erythrocytes. So if 40% of your lymphocytes are larger than erythrocytes, there's a good chance that you are dealing with lymphoma. And we want to look at all the corroborative evidence of no plasma cells, essentially everything is lymphocytic. Now, a lot of times in lymph node aspirates or even tumors, you will see these little fragments of cytoplasm. See some there and some there. And those are known as lymphoglandular bodies. I do not find them particularly diagnostic because you can see them both in severe hyperplastic lesions and neoplasia. And these are likely fragments of effete or apoptotic lymphocytes. But it is a clue that that lymph node is proliferating quickly. Well, let's take a look at this one. Now, unfortunately, we don't have a erythrocyte, but this is the left ear of a dog. Okay, so can't really tell what the size of it is, but this is a skin lump. It was a 2-year-old dog from the left ear. First question is it inflammatory or neoplastic? I don't see a single neutrophil, so why would I think it's inflammatory? What is the predominated nucleated cell type? Well, it's this large histiocytic looking cell. A couple of these have some indented nuclei. They all look about the same. There is some pleomorphism. Okay, if you look within a lot of these tumors, you may see some lymphocytes scattered through. Okay, this is a round cell tumor. This is what a histiocytoma looks like. And the reason we came up with that diagnosis is based on the species. It's a condition of dogs, the age, generally a young animal, although you can see these in older animals as well, the location, and this cytology. The cells look like histiocytes. They have large nuclei with inapparent nucleoli, and occasionally you will see reniform nuclei. Now, not all histiocytomas look like this. Histiocytoma is a skin tumor of dogs which during the course of progression, especially in a young dog, when it starts to exhibit major histocompatibility to antigens, it undergoes spontaneous regression. It will be infiltrated with lymphocytes. And some of these neoplasms that you get, if you get them late in the course of disease, the predominant cell will be a lymphocyte, a mature lymphocyte. And some of these cells will be scattered throughout. So you have to look at the entire picture. And I think this is a lot more key in cytology than it is in anatomic pathology. Okay, it is good to look at these blind to start with, but In rendering cytologic diagnoses, the signalment, the history, and any corroborative evidence is often very important in coming to a final cytologic diagnosis. So I was taught by Don Mutin, don't be afraid to play the vet game. The bottom line is that you owe the most appropriate diagnosis. So use all the information available to you, including age, location, history, and use that material to rule in or rule out your cytologic diagnosis. Now here's one where the history would be very important. Okay, this is one from a mass on the penis of a dog. And when you're talking about the penis, or you're talking about the vulva, or you're talking about the face, especially the nose, and you're looking at round cell tumors, okay, transmissible venereal tumor has to be on your list. And it is pretty characteristic neoplasm, okay, because it is a uniform population of cells. And this one stands out because it's much larger, but it doesn't look like the other cells. So this very well may simply be mucosal epithelium. But one characteristic of transmissible venereal tumor cells is they have deep blue cytoplasm with these very discrete cytoplasmic vacuoles. And if you see this from the genitals of a dog, this would be very appropriate diagnosis for transmissible venereal tumor. And this is what they look like grossly. These are very interesting neoplasms. They have only 59 chromosomes. During transfer from susceptible host to susceptible host, they do not exhibit major histocompatibility antigens, and over time these will regress, just like those histiocytoma. Plasmacytoma or plasma cell tumors are commonly seen in the skin of the ears, the mucosa of the ears, of the oral mucosa in dogs. They are round cells primarily with an eccentric nucleus. They look like plasma cells. They have a range of sizes and often show moderate anisokaryosis or different sizes of nuclei. And bi- or trinucleated cells are occasionally seen. Now these are cutaneous plasmacytomas. The problem occurs when plasma cell neoplasms are present in the bone, which is what we call multiple myeloma. And generally, if you see this picture from a bone, you have to consider the possibility of osteosarcoma or plasmacytoma. Both of these neoplastic cells are densely blue because of the high concentration of rough endoplasmic reticulum in the cytoplasm. Rough endoplasmic reticulum is high in protein. It stains blue because osteosarcoma cells are making matrix and plasma cell tumors are making antibodies. Both proteins that will be, or compounds that will be excreted from the cell, so that those materials are always made in rough endoplasmic reticulum. And if you look right by the nucleus, you will often see a prominent Golgi zone or HOF. We're looking at another plasmacytoma. This is from the skin. What I want to point out is the presence of these large binucleate or trinucleate cells. Still a plasmacytoma. Occasionally you'll see some with characteristic features of malignancy, but you often don't. Okay, and here's a cell which obviously has a very large multilobated nucleus. I don't think it's very difficult to make a diagnosis of malignant plasma cell tumor based on that. And we're going to look at plasmacytoma and osteosarcoma a little bit later on. So here is the bottom line on our round cell tumors. Mast cell tumors, you're going to see hopefully metachromatic granules or purple granules within the cytoplasm, and you may see eosinophils within the stain. The absence of eosinophils does not preclude a diagnosis of mast cell tumor. Histiocytomas are generally young dogs. They are a monomorphic population of cells with abundant light blue cytoplasm and reniform nuclei. Transmissible cell tumors are often diagnosed based on location, and that locational diagnosis is confirmed by the presence of monomorphic cells with deep blue cytoplasm and very discrete clear vacuoles. Lymphomas, well, we looked at all the rules for lymphomas, but they tend to have no other inflammatory cells, no plasma cells, no neutrophils, minimal blood, and 40% or more of the cells should be blastic type, meaning they are significantly larger than erythrocyte. And plasmacytomas, at least the ones in the skin, the oral cavity, or the GI tract, generally have eccentric nuclei with a prominent Golgi zone. A lot of times you can't tell the difference, so you end up making a diagnosis of round cell tumor, and when you have to make a diagnosis like that, there's no shame in it. Diagnosis of round cell tumor at least provides a therapeutic plan for the clinician when you ask for that excisional biopsy. We've looked at epithelial cell tumors, we've looked at round cell tumors. Let's look quickly at mesenchymal tumors. As we said before, mesenchymal tumors are spindle-shaped. They have tails, which are very important. And I teach my residents that tails on cells trump anything else. They're trying to figure out what it is. They tend to be individualized. They don't stick together. They do not have desmosomes. Now, as I said before, someone who's heavy-handed could make tails on round cells or epithelial cells. But generally, when someone is pressing too hard, those tails all go the same way and they are parallel to the long axis of the slide. You are pulling that cytoplasm out, but you're pulling it parallel to the long axis of the slide. If you are looking at a cytology and you think you see tails on these cells, and they're going all different directions, especially in the same field, it is likely not to be an artifact of preparation. Sometimes, very rarely, you can see real matrix holding these cells together. They'll come off in a small clump. You can still tell that they're spindle cells, and in between them, you will actually see matrix, which often stains eosinophilic. One difficulty arises when the cytology is of a recent wound, because fibroblasts often show very similar features to malignant mesenchymal cells. So you have to be very careful. This is a fine needle aspirate from the skin of a dog. And this is on top, we're looking at cytology. It's a fairly bloody tap. But what I want you to see is that the cells have prominent tails. There's one there. There's one there. There's one there. Okay? And peripheral nerve sheath tumors often have these light cytoplasmic vacuoles. This one is not the most diagnostic field. I would probably, if I knew that this was from the leg of a 13-year-old dog, there is no shame in saying that this is a mesenchymal neoplasm, and I favor peripheral nerve sheath tumor or nerve sheath tumor. It is the most common by numbers. It is a good location for it. You don't have to say, if you're not comfortable, don't come out and say peripheral nerve sheath tumor. Okay? But you could say that it's certainly within the diagnosis, and then excisional biopsy should be performed. Okay, we're looking at a 10 centimeter diameter, non-ulcerated mass, the hind limb of a dog. Are we going to worry about granulation tissue? Probably not, because we're using that history. Okay, it'd be very unlikely for a dog to have a 10 centimeter diameter, non-ulcerated mass of granulation tissue. Okay, so the history is key, and when you look at these cells, you can still see tails. Okay, here's some that, here's another tail here. There is marked variation in cell size, and you can see that these cells are locked in some type of matrix here. And this turned out to be a peripheral nerve sheath tumor, or what some people will call a hemangiopericytoma, based on the whirling around vessels. With most mesenchymal neoplasms, don't worry about getting it all the way down to hemangiopericytoma, peripheral nerve sheath tumor, fibrosarcoma, etc. Okay? These are tumors that need to be graded in terms of low grade versus high grade. We generally cannot do that with cytology. The most important thing is to say this is a spindle cell sarcoma and recommend excision with wide margins. Okay, little case presentation here. We are looking at the radiograph of the femur of a cat. And this animal had had a broken femur, and it had a intramedullary pin put in properly. Several months to a year later, it comes back, and you can see that the bone disappears from here to here. There's basically no femur left. There is a large mass lesion, mid-shaft diaphysis of the femur. Okay, so there's lysis of the bone. Your differentials at this point would be obviously osteomyelitis. Maybe it wasn't the most clean technique. Osteosarcoma, not common in cats, or other neoplasia. Okay, occasionally you can see carcinomas metastasize to the bone. We know in the cat that there are certain types of carcinoma, like pulmonary carcinoma, that really likes to metastasize to the limbs, especially the digits. So those are things we need to consider. You prepare for an aspirate, and here is your aspirate. Okay, on top we see spindle cells, round cells, largely, round cells which tend to have small tails here. Okay, they have a lot of dark blue cytoplasm. Are there any neutrophils? No, not really, so it's not inflammatory. I think we can rule out osteomyelitis, and the cells are fairly monomorphic. But as you travel around this slide, you come across this large multinucleated cell. And the cells have some vacuoles. There's one neutrophil here, but there's blood, so you have to consider the possibility of peripheral blood or a bloody tap. So, what are you thinking? Well, it comes down to osteosarcoma or plasma cell tumor, and the two of those can be very difficult. But with this large multinucleated cells, osteosarcoma is the most likely diagnosis. Okay, I think that there may be some wisdom in leaving the door open a little bit. Okay, so I would certainly mention the possibility of a malignant plasma cell tumor as a remote possibility in the body of your letter. Occasionally, in osteosarcomas, you can actually see the osteoid matrix. And that's one reason that this particular clump of cells came off as a clump and rather than individualized cells as we see before, because it is enmeshed with that osteoid matrix. So key to diagnosis here is, in fact, is lytic bone lesion, spindle cells, and the presence of osteoid. You certainly would not see that with a plasma cell tumor. Lytic bone lesion, differential diagnosis, and how do you decide? Well, plasma cell tumors tend to be individualized. They have no matrix. And it is much less likely to see those large multinucleated osteoclast-like cells. So as we compare these two tumors, okay, both of them will result in a lame, sick animal. Osteosarcomas generally arise in one tumor, in one bone, whereas myeloma will pop up in multiple bones, including flat bones. There are breed predispositions for osteosarcoma, including the giant breeds of dogs, and we all know the characteristic locations in the distal radius and the femur. Radiographic pattern, with osteosarcoma you often have osteoproduction, generally in the form of new bone growth to try and stabilize that moth-eaten bone. With myelomas, you generally have lytic punched out lesions because plasma cells appear to be in some way in synchronization with osteoclasts. You get a lot of lytic bone change, but almost they don't turn on the osteoblasts. Obviously, clinical pathologic abnormalities are associated with multiple myeloma, including monoclonal gammopathies and proteinuria in some cases, which we generally do not see with osteosarcoma. Another case, in the upper left-hand corner, we see a picture of a cat which has a lump at the base of the neck. Fine needle aspirate yielded the two images that we see. On the bottom right, we can see that this aspirate is composed of numerous, largely individualized spindle cells. Notice that a lot of these cells have tails. The tails are oriented multiple directions, so I don't think it's just because somebody pressed too hard, not hard enough to rupture the cells, but hard enough to stretch them. I don't think that's the case here. And as I tell the residents, tails trump everything. Because a lot of times you'll get cytologies where you're not really sure whether it's epithelial, whether it's round cell, or whether it is a spindle cell neoplasm on first blush. But when you start seeing tails, that's pretty difficult evidence to refute. In the bottom left-hand corner, we can see that this neoplasm also had numerous multinucleated cells. And here we have a comparison. What I didn't show you on the previous slide was the really large multinucleated cells, up to 60 nuclei. And this was the histologic picture from this particular neoplasm. Being in that it was the base of the neck, I think that a vaccine-related sarcoma would have to be high on your list. But we did not see in this particular aspirate lymphocytes or macrophages filled with the amphiphilic material we usually associate with vaccine material. But looking at the history, and we always look at the history with cytology, a 6-year-old cat, the lump on the back of the neck, it certainly has to be in the differential diagnosis. Other things that you would want to put in there would be a fibrosarcoma, and then of course the giant cell tumor of soft parts, which histologically this most represents, because we have that combination of uninuclear fibrocytic or histiocytic-like cells, and then these large macrophages these large neoplastic cells with numerous small nucleoli. There's nothing wrong with offering a differential diagnosis as part of a cytology. But when you look at the differential diagnosis, you're giving very useful information. A fibrosarcoma, a vaccine-related or injection site sarcoma, those are two fairly aggressive malignancies in cats. And then giant cell tumor of soft parts is also a low-grade malignancy, but you've given the clinician a lot of information here to enable them to develop their treatment plan, which I hope in this case involves surgery early with wide margins. So just to come back to what I think is an extremely important point for doing cytology, or a couple of them. Number one, use the history. Okay, and then the second thing is you're not going to get to a definitive diagnosis on the majority of cases. That is not the ultimate in doing cytology. But to be able to give a clinician a good differential diagnosis is, that's a good day's work done. We are looking at the south end of a dog. There are multiple large masses around the anus, the largest of which is ulcerated. And on the right we have a fine needle aspirate. Think about what we're seeing here. Are the cells individualized? No, it is a cluster. Okay, which should tell you that we're looking at a epithelial neoplasm. And then from this area, obviously the most likely, if you just looked at the numbers, in a male dog, especially one who is not castrated, is going to be the perianal gland adenoma, also known as the hepatoid adenoma, because of its resemblance microscopically to liver cells. And if we look at this clump of cells, we can see that sort of hepatoid appearance. And then around the outside of this clump of cells, we see some smaller nuclei of cells with less cytoplasm. And these would be the reserve cells we would expect to see. So this is what you would expect with a perianal gland adenoma. Nuclei are about the same size. They have small nucleoli, no evidence of malignancy here, and a diagnosis of perianal gland adenoma would be perfectly appropriate. As we know, these are more common in intact male dogs, and they're not just seen around the anus, but they're most common there. You can see them anywhere on the dorsal midline, on the tail base, and up over the back of the dog. Now, that's not the only neoplasm that we see in the perianal region. That is the most common. The other neoplasm that we have to be concerned about, but one that we see more commonly in female dogs, is a neoplasm that arises from the apocrine glands that line the anal sac. Okay, these are aggressive malignancies. They are epithelial cells, and they have a habit of metastasizing internally well before they're observed externally from the dog. Okay, they tend to metastasize down into the pelvic cavity before they come out where you can see them. These neoplasms also secrete a hormone which is related to parathyroid hormone, so these affected dogs commonly present with hypercalcemia. One of the tricks on this particular neoplasm is that the cells look quite benign. They also have very small nuclei. You don't see the bizarre features of malignancy you will see with other carcinomas, but they also don't have that hepatoid or that liver look to them. You tend to see acini if you're lucky in this. And this is what we see histologically with the anal sac apocrine gland carcinoma. We see these cells with much less cytoplasm. There are occasionally multinucleated cells and a small amount of anisokaryosis. If you look very closely, you may see some features that are reminiscent of acinine. You can see a nice one here, and it appears to be a lumen in the middle, and perhaps one right here. And histologically, these glands or glandular tumors produce rosettes on a regular basis. So somewhat different, but the prognosis is markedly different, with anal sac apocrine gland carcinomas giving a guarded prognosis at best. Okay, we're looking at the urine of a dog. Let's just go through the steps. Obviously, we have a well-stained, adequately cellular smear. I would suggest, based on the fact that we can see numerous bacteria as well, the cells are crowded, that this is a spun urine sample from a dog, which concentrates everything. And as we look at this, we can see a number of different cell types. Okay, there are erythrocytes, we have numerous bacteria, and then we have these cells with abundant light blue cytoplasm. They do appear to be adherent. That's a little more difficult to tell when you spun it down, but it looks like these cells are stuck together. Okay, some have very small nuclei, some have very small nuclei, some have large nuclei. There's marked variation in size. And if you think about where it comes from and the species, we can answer some questions about this. First of all, the first question is always, are there neutrophils? No, there are not neutrophils, so we can pretty much establish it's not an inflammatory lesion, even though we do have some blood, we do have some bacteria. It is a pleomorphic epithelial cell population, thinking of what you might see in a dog with hematuria. A diagnosis of transitional cell carcinoma of the urinary bladder is very appropriate here. And this is what it looks like histologically. You can see, and this is the metastasis from the lymph node, but you can see that the cells are joined to each other. There is moderate variation in nuclear size. And although it was not apparent on the cytospin of the urine or the urine sediment, it has that very characteristic vacuolation that you will see in a percentage of cells with transitional cell carcinoma. One of the most confusing things in evaluating neoplasm cytology over the years for me has been to identify criteria of malignancy. And each successive textbook on cytology lists different criteria of malignancy. They list more criteria of malignancy, and the list is actually quite long. Here's a list. The first four are taken from a textbook. You have a hypercellularity of smears, pleomorphism of cells within the same line, like we just saw in that transitional cell carcinoma, disorganization of cells within clusters, and occasionally very large cells with multiple nucleoli and multiple prominent nucleoli, which is also another way to say pleomorphism. Okay. What I've found over the years is what works for me is just identifying marked variability. It's uncommon to get cytologies that you are absolutely sure that you're dealing with malignancy. Sometimes you'll see them. We have such great pleomorphism, they will jump out at you. But I think the key here is note the variability. When you see significant variability within the same cell lines, I want you to think about the possibility of malignancy. And there's one other feature that we will see later on, a feature called nuclear molding, which I have had a lot of trouble over the years. And then finally someone explained it to me in very simple terms. And I think I have a good handle on it now. And we'll talk about that shortly. Here we are again. But we're looking at the nucleus rather than the cytoplasm or the cellular features. Increased nuclear size, variation in nuclear size and shape, large irregularly shaped nucleoli. Now remember, if you spend all of your time looking at 100x, these features are going to be enhanced. Or if you use other stains you're not familiar with, like new methylene blue, enhances some of these features. And it may make a benign neoplasm look somewhat malignant. Okay, multinucleated cells, and we saw that earlier with osteosarcoma and with myeloma and with that injection site sarcoma or fibrosarcoma. Okay, and increased mitotic figures. Okay, if you have a very high mitotic rate, especially in a aspirate from a lymphoma, you should be considering the possibility of malignancy. And of course, as you see more of these criteria in the same cytology, the chances of malignancy increase. Just a couple of obviously benign tumors, which are not really exhibiting any of the signs that we look at. When we look at the mammary adenoma, you can see the cells are all the same size. They are clustered together. Nuclei are the same size. The nucleoli are not prominent. This is about as benign a cytology of a neoplasm as you would expect. If we go back to our perianal gland adenoma on the right, the nuclei are small, nucleoli are not very prominent, and the orientation is what we would expect. In the center of this cluster, we see the large hepatoid cells. On the outside of the cluster, we see the reserve cells, just like we would see in tissue section. As we look in epithelial cells, or on the right, a mesenchymal cell for evidence of malignancy, they start to become somewhat more apparent as you have more of a range of nuclear to cytoplasmic ratio, with the nuclei becoming larger. We have several multinucleated cells in the carcinoma on the left, and the nucleoli are very prominent on the left. If you take a look at the sarcoma on the right, we have one cell which dwarfs the other cell in terms of cell size, in terms of nucleus, and a large macronucleoli. Now, I'm very hesitant to diagnose malignancy based on a single cell, and I won't do it. But if you are looking around the cytology and you notice other cells or other clusters which contain similar appearing cells, then the potential for malignancy in this aspirate goes up dramatically. We're looking at the aspirate of a dog with histiocytic sarcoma, and look at the variation between the small cells on the left of this cluster and the gigantic cell on the right. Okay. Also, if you look right here, you can see that, get my pointer, you can see that this cell has phagocytized a erythrocyte, and down here in this area, underneath these other nuclei, you can see granules of hemosiderin. Here's another, possibly another cell, or maybe the same cell, and another phagocytosed erythrocyte. And when we're dealing with histiocytic sarcomas, one of the other features of malignancy is the predilection to phagocytize things around them. I want to take a little bit of time to talk about lymph node cytology, because after skin tumors, lymph nodes are the second most common submission, at least in our practice, and probably in most pathology practices. The indication for aspiration of enlarged lymph nodes would be especially if they are hard. Remember that in older animals, lymph nodes tend to be surrounded by a pretty prominent layer of adipose tissue, and it's very common to get aspiration of nothing but fat where it's submitted with a history of enlarged lymph nodes. If a lymph node has lymphoma, it's generally hard. It's being packed with cells. It doesn't have the give that it used to. And a very important thing that I tell the practitioners is that if a lymph node is of normal size, the chance of finding anything is extremely small. Normal lymph nodes are generally normal size. There are a number of causes of lymphadenopathy that we will see. The most common is probably hyperplastic or reactive lymph node, where you are draining an area of inflammation. This is very common in the cervical lymph nodes in older dogs because of inflammation in the oral cavity in the form of periodontal disease. Occasionally, they will become actively inflamed, where you will see the presence of neutrophils or eosinophils within that lymph node aspirate. Primary neoplasia in the form of lymphoma is also common, and metastatic neoplasia, not very common. Usually there's a history of the animal has had previous neoplasm removed, or there is a lump in the area drained by that neoplasm. Most common ones that we see are mast cell tumors and melanomas. Well, here is your first lymph node aspirate. And I want you to take a moment and think about it. And let's decide what we're looking at. Okay, remember that in the dog, a normal mature lymphocyte is roughly, maybe a little bit larger than an erythrocyte. Okay, if a cell is larger than a neutrophil, generally we are blastic. Other things that I look at is not only the size of the cells, but the amount of cytoplasm and the color of cytoplasm. Okay, in here we are looking at a range of cells. The majority of them are small, mature lymphocytes. And then we have 3 or 4 blast lymphocytes. Okay, so we have sort of a range. The other cell on the right-hand side, which is demonstrated by the large arrowhead, is a Mott cell. This is a plasma cell that has large vesicles containing antibodies. So looking at the range of cell size and the fact that we have a plasma cell in there, I'm not thinking about lymphoma. I don't have other cell types I would expect with active lymphadenitis like neutrophils or eosinophils, and my diagnosis here would be a reactive lymph node. The keys to diagnosing reactive lymph nodes is that the node is enlarged, the predominant cell is going to be a small lymphoblasts. Plasma cells will almost always be there. We're looking at a nice one here. You can see the dark blue cytoplasm because of all the rough endoplasmic reticulum. There's generally a paranuclear HOF, and the nucleus is eccentric. Plasma cells can be up to 20 to 30% of the cells in your aspirate, and lymphoblasts should be there, but they should be 20% or less. Okay? Occasionally, you will see macrophages, you will see neutrophils and other cells, but they will not be the balance of the inflammatory cells. And you will see erythrocytes. Okay? There is enough room in that node for blood to go through, and the aspiration process will probably cause a bit of hemorrhage. So this is a reactive lymph node, it's a wide range of cell types. Okay, now we are looking at an aspirate from a enlarged hard lymph node. What do we see here? Well, I do see erythrocytes, but the predominant cell here, I see one small mature lymphocyte right here. The majority of these cells are large. They're significantly larger than the neutrophil. So these are blast lymphocytes. It appears that we have one or two cells here either with an irregularly shaped bilobe nucleus or that are multinucleated. This one actually looks cleaved. Okay, and then we have all of these small blue bodies, which are known as lymphoglandular bodies. And lymphoglandular bodies are seen whenever you have rapid proliferation of lymphocytes. They are probably fragments of damaged cells or apoptotic pieces of cells. You can see them in reactive lymph nodes as well as seeing them in neoplastic lymph nodes. But it just tells you that you have a rapid increase of cells here. Well, if we take our criteria, it looks like the dominant cell is the lymphoblast, so this is one that I would seriously consider the possibility of lymphoma. So lymphoblasts are the predominant cell type, only one lymphocyte, and numerous lymphoglandular bodies. Note there's no plasma cell here. There are no neutrophils or macrophages or anything else. It is very nice when you get the aspirates of the hard lymph nodes that are totally monomorphic and all the cells look alike. But the vast majority of what you see, there will be a range. So that cutoff of 50 or even 40% lymphoblasts is something that we rely on here at the AFIP to make our cytologic diagnosis of lymphoma. Obviously, when you're dealing with something like that, we always recommend excisional biopsy, for definitive diagnosis and to, get a good look at the architecture. It also allows us to perform immunohistochemical stains to see if we're looking at T cell or B cell lymphoma and give more accurate prognostic information. One thing we haven't seen in these aspirates are the presence of mitotic figures. Just realize that you can see those in lymphoblast population in reactive nodes as well. So the presence of one or two mitotic figures in a lymph node aspirate should not automatically make you leap toward lymphoma. Although the slide says 50% of cells should be lymphoblasts, I think today we probably will make a diagnosis of lymphoma if you have 40% lymphoblasts, as long as there is no other evidence of significant reactivity in the node, meaning that there will be few plasma cells, no other inflammatory cells. The aspiration of lymph nodes is somewhat based on luck. There are 60 or more types of lymphoma with varying architectures that have been diagnosed in domestic animals. Okay, I don't know if all of those are true, but the experts say that there are 60 or more. Okay, and they all have different types of architecture. And based on how you aspirate these nodes, and if you make one stick or you make multiple sticks, you can have aspirates from the same node which look extremely different. So I like to have several aspirates to evaluate, but the bottom line is, if I'm seeing more than 40% lymphoblasts, mitotic figures, and an absence of plasma cells or other cells associated with antigenic stimulation, I'm probably going to come down on the side of lymphoma. So here we go, looking at reactive versus lymphoma. The predominant cell in reactive node is going to be small lymphocytes, and in lymphoma it's going to be lymphoblasts. Okay, which may be 40% or more. There will be numerous plasma cells in reactive nodes. Those take a long time. Okay, and few to no plasma cells in lymphoma. Identifying the cause of reactive nodes is almost never possible, and a lot of times we just look at the location of the nodes, and if it's in the neck, we may put in the letter that this is often the result of oral disease, and certainly careful examination of the oral cavity is warranted. Here's a fine needle aspirate from a lymph node. What we see is abundant fat, and then mixed in there, I think you can see small numbers of lymphocytes. As we said before, this is what we see commonly in older dogs and with practitioners who don't do a lot of cytology. Generally in universities, there is a clinical pathologist, or in Europe, an internal medicine specialist who have done lots of aspirates, and rarely do you get this. But what we're looking at is aspiration of the fat around the lymph node. I do not see intact adipocytes here. What I see is essentially cell fragments. The fat is there, the cells have been fragmented by going through the needle, and you end up with these very small vesicles. So this is aspiration of the fat. Another common error with people who don't do a lot of aspirates is, especially in the cervical lymph nodes, is to aspirate a salivary gland. We'll get that from time to time, and you will have a history of enlarged cervical lymph node, and the aspirate will consist of few clusters of epithelial cells. Rarely you might even see a acinus. And this tells you that the salivary gland has been aspirated instead of the cervical lymph node. So this is one that you just send back and you say, you're going to have to re-aspirate. Normal lymph nodes, generally you will see the predominance of lymphocytes about the size of erythrocyte, maybe slightly larger. The rare plasma cell, almost all the cells have dense chromatin patterns. They have a small amount of cytoplasm. And the bottom line, if the lymph node appears normal, don't aspirate. Even if you have dealt with a mast cell tumor recently, if the lymph node is normal, the chances of coming up with metastasis on an aspirate is minimal. As we said before, number of lymphoblasts is generally less than 20% in a normal lymph node. Lymphadenitis. When we deal with, or as we say here, lymphadenitis, one of the predominant cells may not be the largest population, but the number of neutrophils or perhaps eosinophils will be significant. You'll always get large numbers of lymphocytes, both mature lymphocytes and blasts. You may see some plasma cells because you have all of these follicles. You have the paracortex, which is already full of lymphocytes. There's not that much room for neutrophils to come in, but they will be in large numbers in these lymph nodes. Granulomatous lymphadenitis can be somewhat difficult to differentiate from a lymphoma, because you will have a mixture of lymphoblasts which may be very similar, unless the macrophages, of course, contain something. Etiologic agents may be present. They may have been carried into the draining lymph node, okay, in the form of bacteria, especially intracellular, or protozoal or fungal agents. But a lot of times they're not present. Here's a case of granulomatous lymphadenitis. Okay, notice how some of these cells resemble lymphoblasts. Okay, a dense chromatin pattern and abundant cytoplasm. But you can see that these cells, as opposed to lymphoblasts, contain large lysosomes. They have granular material within the cytoplasm. This one may even have engulfed a neutrophil. And that's not something that lymphoblasts are going to do. Okay? Or they may phagocytize an erythrocyte and have hemosiderin. Another key that you are likely dealing with macrophages other than lymphoblasts are the presence of numerous neutrophils within this aspirate. And this was from an aspirate. One of the macrophages contained a large budding yeast. This yeast is larger than a neutrophil. So hopefully you have identified this as blastomycosis. Larger than neutrophil. Remember, if this was histoplasmosis, you would see numerous organisms within macrophages, and they would be smaller than erythrocytes. This is a different appearance. The cells are of the same size as lymphoblasts. But one thing that you should be able to note with these large blue cells is that they are cohesive. They stick together. And usually what happens with carcinoma, which metastasizes to the lymph node, is you get clusters of cells. There are some isolated cells, but you have clusters of cells. The node itself is not especially reactive. Okay, you see, we don't see plasma cells. I see a neutrophil or two in here. Okay, but the predominant cell is a small lymphocyte. So this would be a somewhat difficult diagnosis to make, if you were making it cold. Most of the time when you're dealing with aspirates from metastatic tumor, the tumor has been previously diagnosed, or at least you'll have a description of a lump in the area of this particular node. Note the presence of a large vacuolated cell with an indented nucleus. This is a macrophage and not a carcinoma cell. It is fairly uncommon in my experience to see lymph nodes with metastatic sarcomas. Sarcomas tend to be more infiltrative. Okay, they do not tend to get into lymphatics to metastasize nearly as often as carcinomas, but every once in a while you can have a lymph node aspirate with numerous spindle cells. And this is from a dog with a large fibrosarcoma within the mouth. So, talking about, just to sum up, metastasis or metastatic neoplasms within lymph nodes. Metastasis of any malignant tumor is a possibility. Anything can go what they want. And sometimes you will see metastasis of tumors that do not result in obvious cells in the lymph node, but histologically the lymph node will be enlarged. And when you section it, the vessels are markedly dilated. That's more of a histologic diagnosis, and that is because you have occlusion of lymphatic drainage downstream. Epithelial cells, you can confuse them with macrophages. Look for clusters. Look for the clusters. And if you see clusters of cells forming acini and you don't see any lymphocytes, you obviously, especially in the cervical area, want to consider the possibility that a salivary gland was aspirated. Some very good friends of mine, excellent clinical pathologists, believe that cytologic aspirate of enlarged nose for metastasis is as good as predicting the presence of metastasis as histopathology. And I would say that's probably true, because when you have an enlarged lymph node due to metastasis, usually there are numerous metastatic neoplastic cells within it. This is something that we get from time to time, and usually it follows a previous diagnosis of mast cell tumor. And when you look in the the aspirate, you will see clusters of mast cells. 2 to 3 is, you can see 2 clusters of mast cells within a lymph node in normal lymph nodes. Okay, just the presence of mast cells doesn't mean that you're dealing with a mast cell tumor. Mast cells line vessels throughout the body, and they line vessels in lymph nodes as well. Okay, if you are seeing 3 or 4 or more clusters, especially in the presence of eosinophils, then the likelihood of mast cell metastasis goes up significantly. This was a fairly obvious cytology from a lymph node with metastatic mast cell tumor, and it's not very difficult. But just realize you can see individualized mast cells, and we tend to look for clusters of mast cells of 2 or more. And when you get up to 3 or 4 of those, your index of suspicion should go up. And here's a nice review of this, which essentially rates it as possible, which is 2 to 3 aggregates. 4 or more is probable, and if you see 6 or more, then, or 5% mast cells in the specimen, it's almost certain metastasis. I think that the last line here applies not only to mast cell tumors, but to all lymph node aspirates where you're looking for metastasis. And you can have false negatives, especially in sarcomas or carcinomas, okay, where you simply don't aspirate appropriately, or cells are damaged and you can't interpret them. So beware of false negatives. They're not uncommon. Here's one where the stain is not great. We cannot pick up nuclear features, but look at the number of granules and look at how the granules are spread out over the slide. Okay, as we said before, when you are doing looking at mast cell tumors, you'll rupture a number of these cells, but the granules will spread out and they will occupy the spaces between the cells. Occasionally, you will see mast cell tumors which are very poorly staining or have poor granularity. And this one was restained not with the Reitz-Romanowski stain of Diffquick, but a traditional Reitz stain, okay, which tends to accentuate the granules better. Okay, and notice right down here, hopefully you realize dark blue cytoplasm, an abundant cytoplasm, eccentric clock face nucleus. Okay, this is a plasma cell. Here's one quick quiz for you before I take a short break. This is an aspirate from the lymph node of a dog. Take just a moment. You can see that the aspirate is composed primarily of very large polygonal cells with abundant cytoplasm, small nuclei, okay, with dense chromatin pattern, and you can see these linear streaks within the cytoplasm. Any ideas? Well, the streaks that you're seeing in the cytoplasm are bacteria in negative relief. So these bacteria do not pick up the diff-quick stain, but histologically, or if you have the ability to do acid-fast stains, you would see that all of these bacilli are acid-fast. This was a case of Mycobacterium avium infection in a dog. I want to go over a number of aspirates with you, and some of them will be impression smears. So let's just call them our cytology case studies. And I want you to do all of the answer all the questions we've asked before. Okay, all of these will be, for the most part, adequately stained, adequately cellular. But let's remember how we approach these. First question is going to be, are there neutrophils or not? Are they the predominant cell? If we go to a neoplasm, if we decide there are none, we're going to a neoplasm. We want to start with, are the cells are they individualized? Are they in clusters? Are they stuck together? Are they cohesive? Are they spindled? Are they round? All the things we've talked about, and I will try and talk you through all of these. I'm going to start off with a very easy case, a sub-Q mass from the thorax of a dog, okay? And we are looking at numerous cohesive, clear, polygonal cells with very small nuclei, okay? They came off in a cluster, and you can see that we also have abundant environmental debris. This is not interpretable. These are just keratin bars, and they might have come from the person that was making the aspirate. This, of course, is a lipoma. And you very rarely see these because during the preparation, okay, during the aspiration, a lot of times the cells do not come out nicely like this. They're fragmented like we saw before, and the alcohol that's used as part of the staining procedure often will dissolve these cytologies. Okay, if you're aspirating a lipoma, generally when you shoot this out on the slide, when you make your preparation, it'll be very greasy. And I'm not saying do not aspirate lipomas, because one of the major differentials for lipoma, and the two can look and feel indistinguishable, are those peripheral nerve sheath tumors or hemangiopericytomas, which can often be sort of soft and gooey like a lipoma. So I'm a big fan of aspirating these neoplasms, and then you can make your treatment plan afterwards based on whether it is a nerve sheath tumor or whether it's a lipoma. Note that I do want to mention that the diagnosis here is lipomatous tumor. I would probably go with lipoma, but once again realize you can't always tell benign from malignant. Something like this is invariably benign in my experience. Okay, we're looking at the perineum of a bull terrier, and we have a large ulcerated mass. Okay, the aspirate is on the right. This is another slow pitch for all you cytology experts. At this point, we are looking at numerous individualized round cells with centrally placed nuclei and abundant purple granules, some of which have even ruptured and the granules are still visible. This is obviously a mast cell tumor. And can you grade this one for me? Is it low grade or high grade? If you said that it is low grade, you're wrong. If you said it's high grade, you're wrong. Okay, what I'm hoping for you to say is that you can't grade on cytology, and that's absolutely true. Other cells that I see in here, of course, numerous erythrocytes, we have a neutrophil, and here's a spindle cell. Okay, this might be a fibroblast or maybe some granulation tissue around there. Okay, But when you see this many mast cells, we're not gonna think, oh, there's a spindle cell tumor. Not with this many mast cells. And the gross appearance of a mast cell tumor. Okay, we're looking at a mass on the ear of an 18-month-old dog. Okay, we have numerous individualized round cells on a background of erythrocytes and some proteinaceous material. The round cells vary moderately in size. They generally have eccentric nuclei with a dark chromatin pattern and a moderate amount of a lightly basophilic cytoplasm. As we said before, monomorph population, neutrophils, there are no granules here. And it's from the ear, so we're not thinking about TVT. What is your diagnosis? Just a little higher magnification. This is a histiocytoma. It is a young dog. It is on the skin. One thing I would like to see here, which I don't, is indented nuclei, but I bet if we traveled around the slide a little more, we probably could. One thing that you would have to consider in this case would be a cutaneous plasma cell tumor or a plasmacytoma. What is missing that would help us make that diagnosis? Well, we don't see the dark blue cytoplasm. We don't see the presence of a HOF. And we don't see the multinucleated cells that really help to, binucleated or trinucleated cells, which are very common in plasmacytomas. This particular neoplasm probably has not been there that long. I don't see any lymphocytes, although we're only looking at one field. And remember, as these tumors regress, you will get a marked rise in the number of lymphocytes and a marked decrease in the number of these neoplastic cells. We're looking at the mass from the neck of a dog. What I see is a large number of what appear to be lymphocytes. Okay, I will assume that this is a cervical lymph node, and then a number of cells, their cytoplasm is partially to completely occluded by the presence of these black, variably sized granules. Very simple case. This is a melanoma. Is it a melanoma or a melanocytoma? Well, if this is a lymph node, we're likely looking at metastasis. So that would make me think obvious malignant melanoma. Melanocytomas are very common, the skin, mucous membranes, etc., but not in the lymph nodes. Okay, we're looking at the radius of a dog, and you can see there is a large lytic lesion in the distal radius. One of the things that is extremely important in our practice is to make sure that you get x-rays when you're dealing with bone lesions. Okay, I see a large lytic lesion. I see minimal proliferation. Okay, and then the aspirate, I see a cluster of cells. They appear to be cohesive. There is marked variation in size, and I see at least one cell on the left, which is twice as large as the rest. It is multinucleated. The nucleoli are very prominent in these cells. This is on a background of peripheral blood. The neutrophils look very good. And with the presence of a lot of blood and neutrophils, I am thinking that this is just peripheral blood contamination. What's your differential diagnosis here? Well, I think just based on the location, the radius, Okay, an osteosarcoma has to be high on your list. Plasma cell tumor doesn't look very much like it, but it's a nice punched out lesion with minimal bone growth. And then the other possibility that you would have to think about is metastatic carcinoma. In humans, up to 60% of carcinomas will metastasize to bone. Well, this one turned out to be osteosarcoma. The cells aren't spindling very well, but looking at the species, looking at the fact that it's in the distal radius, which is a very common possibility, osteosarcoma is at the top of your list. These are a couple of other cases which illustrate what you might see with multiple myeloma. Here we're on the left, we have multiple punched out lesions involving the cortex and the medulla of the humeral, both in the metaphysis, proximal and distal, and the metaphysis. There appears to be a little bit of sclerosis in midshaft diaphysis. On the right is a section of bone where you can see these punched out areas as well. And then the aspirates of these have the features that we expect with the deeply blue cytoplasm, the individualized round cells, and on the right we see a binucleated cell. Okay, these cases generally have other clinical pathologic abnormalities with a monoclonal gammopathy, loss of these monoclonal Bence-Jones proteins, increased serum proteins because of the liberation of all of those light chains, and often hypercalcemia. Okay, we're looking at the mass, a mass in the neck of an adult dog. Is it inflammatory? Do you see neutrophils? No. What we do see are clusters of epithelial cells. The cells have fairly uniform nuclei with moderately prominent nucleoli. And on the right, we can see that they do form acini. It's a glandular structure. And there appears to be some pink material within it. Also within these cells, you have these greenish black granules. So this is a deep-seated focal mass in the neck of an adult dog. So this seems to fit a number of categories. Epithelial, yes. We see greenish black granules, which hopefully some of you are thinking melanoma right now. And it surrounds this sort of pinkish material. This is a tough one. This is a case of thyroid carcinoma in a dog. Let's put it all together. Okay, we have glandular acinar structures. It's the neck of a dog. What you're seeing, the pink material that you're seeing, is going to be the colloid. And those granules that you can even see some of that colloid sticking over here. And then those secondary lysosomes, which are breaking down the colloid, will stain positively, very much like melanin, because tyrosinase is part of that complex. Okay. Note that the cells look very benign. There's no features of malignancy. But if we think back to what we know about histology, endocrine neoplasms rarely show histologic features of malignancy that we see with other carcinomas. They generally have a very low or non-existent mitotic rate. They do not show very much anisokaryosis. Okay, so this is what you would expect on cytology. We're looking at finding a aspirate from the face of a dog. First question, Are there neutrophils? Yes. Are they the predominant cell type? Well, I'd say maybe it's 50-50. There certainly are a lot of them. They are a predominant cell type. So this is an inflammatory lesion. And then if we look at the other cell types, they seem to be large macrophages. Okay? The small nuclei, nucleoli, vacuoles. So our interpretation here would be pyogranulomatous inflammation. And at this point, it would be important to start looking for a cause, realizing that a lot of times you will not see the cause, but we certainly have to look. And we'll break out some of our special stains if we have to. Hopefully we can see it without too much work. This particular case did not show any evidence of anything, but at least we are thinking in the correct way. This one is from the nose of a horse. Once again, are there neutrophils? Yes. Other cell types would include macrophages, which appear to be the predominant feature. Macrophages are much larger than they should be. They are stuffed with poorly staining material, and you can see right here there is a large fungal hypha. We can also see one here and one here. So this is a fungal dermatitis from the nose of a horse. Moving forward, looking at fine needle aspirate from the face of a dog. We can start from the beginning. Are there neutrophils? No. So we're likely dealing with the neoplasm. Okay. The neoplasm here, there are a couple of possibilities, and sometimes you don't get all the way down to the final based only on the aspirate. Perhaps the history was simply from the face of a dog. We don't know whether it's a young dog. We don't know whether it was an older dog. Okay. Looking at the 5 or 6 possibilities, I often lump melanomas in with my round cell tumors. But we have histiocytoma, plasmacytoma, TVT, lymphoma, and mast cell tumors. Well, when we look at this, see if we can get closer. No closer on this one. When we look at this, we know it's from the face of a dog, so TVTs are very uniform. I'm looking at individual round cells of varying sizes. TVTs have cellular cytoplasmic vacuoles. I'm not seeing that here. Okay. Mast cell tumors, there's no granules, so that pretty much takes mast cell tumors and melanomas out of the mix, and it's the face. They didn't say it was the nose, but it's the face, and I just don't like TVT. So I'm down to 2 possibilities. I'm down to a histiocytoma and a plasmacytoma. Here the cells vary markedly in size. There are a number of cells which have small cytoplasm. It looks like there are mature lymphocytes in here. Some of the cells are large. They have eccentric nucleoli, and there is one binucleated cell. I think I'm going to go a little bit off book with this one. My colleague who put this in the presentation likes plasma cell tumor, and I certainly think that is a possibility. My problems with that is that I'm seeing a lot of cells that look like histiocytes. I'm seeing lymphocytes. So I would probably say on this one that I would give a differential diagnosis of histiocytoma and plasma cell tumor. I would recommend, if clinically warranted, surgical excision, because those histiocytomas might disappear. I'd like to know more about the age of the dog. So a younger dog is more likely to be a histiocytoma. And if the clinician wants to, I'm more than happy to look at a second aspirate or a surgical biopsy. Let's look at abdominal fluid from a horse. We're going to approach that just like we do anything else. What is the predominant cell? predominant cell is a neutrophil, but within this image right here, we can see a large macrophage, obviously with a phagolysosome containing 2 rod-shaped bacilli. Here's another neutrophil, slightly degenerate, which is also engulfed bacilli. Interpretation: this horse will die, and will probably die soon. It is likely that we have a ruptured viscus, liberation of bacteria, and septic peritonitis. This would be a septic exudate. And one thing I've learned from clinical pathologic colleagues, or my friends who are clinical pathologists, is to differentiate between a neutrophil exudate or neutrophilic exudate and a septic exudate. When you have septic exudate, usually you have bacteria in there. So seeing the bacteria, I have no problem saying this is a septic exudate in the abdomen of this horse, and that means very bad things. You can see a neutrophilic specimen where the neutrophils are degenerate. If you look, you have hyperlobation here, okay, or sometimes they will swell and you almost cannot see the multiple lobules, and that is, toxic neutrophils. So you can see that if somebody has tapped it and left it in the fluid too long. So I usually reserve the term sepsis or septic exudate for when I have identified bacteria as well. We are looking at a cluster of cells from the abdomen of a dog with ascites. What's the primary cell? It is not a neutrophil. We have clusters of cells. These are most likely epithelial. And when we look at these cells, I can see a couple of features of malignancy here. The first is we have marked variation in size of cells. One cell's twice as large with multiple nucleoli, prominent nucleoli. And then we have something where you can see these cells are hugging each other and the nuclei are folded over each other. And this is referred to in the literature as nuclear molding. I had a lot of trouble with nuclear molding until someone recently observed that these cells are spooning. And if you forgive my romantic reference, but that's what's going on. This cell is spooning the other cell, and it's a great analogy for nuclear molding. And that is another prominent criteria of malignancy. And knowing that this dog has ascites, that will qualify as malignant ascites, which is associated with a neoplasm. The cells are clustered, so high on my differential diagnosis would be some form of carcinoma. I would have to also consider the possibility of mesothelioma here. A lot of times mesothelioma cells will be clustered, but they will be in even numbers like 2 or 4 or 6 or 8. The cells often have a fairly prominent, almost glowing border to them. Okay, so that's in my differential. And for an anatomic pathologist, you'll even get biopsies or necropsy material where you have to run special stains to determine whether you're looking at a carcinoma or you're looking at mesothelioma. So either way, this is a very poor prognosis for this dog, and you're giving excellent diagnostic information to this clinician. This is an aspirate of a sub-Q mass from a cat, and obviously I should have taken this one out. I apologize, it's still in there. But this is a the rest of that. Well, no, these are two different ones. So subcutaneous mass from a cat, we are looking at abundant keratin. There's two possibilities here. This could be a non-diagnostic specimen with a lot of environmental debris, or it could be a very poor aspirate of a keratin-producing cyst or neoplasm. Let's look at something that's a little more diagnostic. We are looking at the mass, a skin mass from the neck of a dog. We have clusters of a monomorphic population of cells which occasionally assume a somewhat spindled appearance. Think about adult dogs, what they might get that would look like that. And this is a basal cell tumor. Okay, look at these cells. They are very small, bland nuclei, and I'm going to flip back and forth, closely crowded into these sort of ribbon-like appearances. And then occasionally, in trichoblastomas or basal cell tumors, around the edges, these cells do assume a spindle appearance. And in here. So you'll get these spindle cells as well. In the dog, we call them trichoblastomas. In the cats, they are still referred to as basal cell tumors, and they are often pigmented in the cat. We are looking at the aspirate of a liver from an older dog. And I know that we have not looked at a lot of visceral aspirates, and that will be a totally different lecture about what normal aspirates look like from a variety. But one thing I want you to look at is the predominant cell in here, with the exception of maybe this cell, which has a much larger nucleus, abundant foamy cytoplasm, which is a hepatocyte. Okay, here's one here. Okay, but the predominant cell is small, about the size of, a little larger than an erythrocyte, small amount of cytoplasm, dark, clumped chromatin, prominent nucleoli. Do those look like liver cells to you? Have you ever seen a dog whose liver cells were the same size as erythrocyte? Of course you haven't. Okay, this is a case of lymphoma, malignant lymphoma from a dog. I think that almost all of the cytologies that we get routinely from dogs are fairly non-diagnostic. The history is often that the dog has elevated liver enzymes. Perhaps it's mildly hypoechoic on ultrasound, and somebody figures that a very cost-effective method will be to stick a needle in there and see if we can come up with something. Okay, almost never diagnostic. I even find, honestly, needle biopsies of those livers to be somewhat difficult. So aspirates would be even farther, but this was one that actually, because it was ultrasound guided, hit a mass lesion in the liver, and we saw malignant lymphoma. This is a skin impression from the toe of a dog. And the dog probably had an ulcerated lesion. Okay, so let's take a look. What do we see? Well, impression smears on ulcerated lesions, especially on the feet, are not very helpful. What I see is a large amount of erythrocytes. And if we look closely, we probably see some neutrophils if it's ulcerated. I see some keratin debris. Not sure if that probably came from the dog. Maybe it's a crusty little lesion. And then I see numerous large polygonal, occasionally nucleated squamous epithelial cells. And keratinized squamous epithelium has this very translucent teal blue appearance. Okay, but if we look around we can see these structures right here. They look like little footprints or bedroom slippers. This is malassezia. And remember, sort of the cutoff is, if you see more than 10 in an area, it might be pathogenic, and we really don't know. This could be primary or secondary, but we do see malassezia. This is one that I said we should be able to diagnose early. I'm glad I have these pictures I shot to put in the presentation. And this dog had a soft fluctuant mass in the upper neck. And it was aspirated. It was soft. The clinician thought it was a lipoma, and aspirated and came out with a lot of, well, let's take a look and see what we have. And I'm going to tell you, I will tell you right now, this is from 2 different cases that I've seen in the last year, but I wanted to point them out because I think that they're fairly diagnostic, and not all these cases look alike. On the first case, what is predominant cell? On the left, well, it's a neutrophil, so we're dealing with inflammation and neoplasia. We are dealing with inflammation. And aside from the neutrophils, there were a large number of nuclei, or excuse me, of macrophages with small nuclei, and they had sort of amphiphilic material, and occasionally you would see these bright orange rhomboid hematoidin crystals. And this is what you see in a number of cases of sialocele in the dog. Generally around the face and neck, they've leaked saliva into the surrounding tissue. You often have macrophages that pick up this material, and there's hemorrhage, so you will see hematoidin granules within macrophages. This is very characteristic for sialoceles. Now, a number of cases that I've seen have another very characteristic. I'm not exactly sure what the product is, but the macrophages within these specimens have these bright greenish blue or aquamarine granules. And I've only seen those in sialoceles. So sialoceles, you will see mixed inflammation, a lot of macrophages, which will either have these orange hematoidin crystals or these bright green crystals. And perhaps this is hematoidin that's broken down a little more. But a nice Kelly green. I don't know of anything else that looks like that. So this is the cytologic appearance of a sialocele. We are looking at an aspirate of a mass over the tibia of adult dog, and these are all cases that came in to the AFIP. Many from either privately owned animals or military working dogs, and this was a military working dog with a large mass over the tibia. Are there neutrophils? No, they're not neutrophils. Okay, these cells, there are clusters of cells which are occasionally spindled. Okay, they are somewhat pleomorphic, mild variation in nuclear size, prominent nucleoli, occasionally binucleated, and some of them are enmeshed in this pink material. A lot of them have somewhat eccentric nuclei and abundant mottled or dark blue cytoplasm. A hard mass over the tibia. Hopefully you came up with the diagnosis of osteosarcoma here, and these have all of the features we would expect of osteosarcoma. Cells are producing osteoid, which we see here. They are enmeshed in it, so they have abundant rough endoplasmic reticulum. Not especially spindle, but you do have multinucleated cells. And the one thing that really is sort of odd about this particular aspirate is the cellularity. Most sarcomas they tend not to exfoliate well. We're looking at a young horse's leg, and we have a mass which is nodular. Are there inflammatory cells? There are inflammatory cells. Okay, they're not neutrophils, they are eosinophils. And there's a second cell population which are individualized, irregularly round, which have a centrally located nucleus with a dense chromatin pattern that are mixed with these eosinophils. This is a mast cell tumor in a horse. Some people just call it mastocytosis. They're not even sure if it's a mast cell tumor, but you do have the population of mast cells, which in the horse generally are not well granulated, and these really nicely granulated, brightly eosinophilic granules of the eosinophils. Here's a mass on the head of a young dog. We can take a look at it. I see individualized round cells, blue cytoplasm. Here's one with a nice indented nucleus, a few lymphocytes scattered through. Put your history and your cytology together. Once again, another cutaneous histiocytoma. Now, we've seen 3 or 4 of these tumors in the course of the last couple of hours. I think that's important because if you do a lot of cytologies, this is one of the things that you get. You get a lot of skin lumps and bumps, mast cell tumors, histiocytomas, the occasional plasmacytoma. It will be your bread and butter. So you don't want to make a mistake diagnosing a histiocytoma or a mast cell tumor. One invariably benign, one invariably malignant. We are looking at a sub-Q mass on the limb of an older dog. We have a very nice chunk of tissue on the right. Okay, we have to look closely. Okay, it looks like a large bore needle was taken. Do not confuse this with a cluster of epithelial cells, because at higher magnification you can see that these cells all have tails. It is that sub-Q mass. It was probably fluctuant, it was probably soft, and the owners came in probably thinking it's just going to be a lipoma. You can see that these cells are surrounded by abundant pink matrix. And this is likely to be it is a soft tissue sarcoma. Okay, and there is a tendency in the literature now to once again, lump a lot of these peripheral nerve sheath tumors, hemangiopericytomas, undifferentiated sarcomas together. Okay, years ago we referred to them all as soft tissue sarcomas, whether they were neurofibromas or schwannomas or hemangiopericytomas or whatever. We would call them all cutaneous spindle cell sarcoma because essentially they're all low-grade malignancies which are very invasive, difficult to excise completely, and tend to increase in grade with repeated attempts at surgical excision. And then for a period of time, over the last 10 or 15 years, there were a lot of papers which were splitting these out, the hemangiopericytomas from the peripheral nerve sheath tumors. And then within the last year or so, the tendency is to start to lump them again into a group of low-grade cutaneous sarcomas in the dog. So it's definitely a spindle cell neoplasm. Based on the history and the appearance, the nerve sheath tumor would be at the top of your list, but obviously the final diagnosis is going to be made on histology. Waxing and waning skin mass of a dog. Another fairly easy diagnosis. Numerous round cells with purple metachromatic granules. And if at close, remember when these cells degranulate, and we have all these granules out here, when they degranulate, they often leave these little white holes. Okay? So This is, once again, mast cell tumor. You don't need to have the eosinophils in a dog. You would probably, if we looked around, you would see them, but this is a large group of mast cells. So, mast cell tumor. Low grade, high grade, sorry, I can't tell you, won't tell you until you send me the biopsy. Okay, we're looking at a sub-Q mass on the dorsum of a cat. And look at these cells. Neoplastic, somewhat multinucleated, but they're granulated as well. These are also, the granules are somewhat different. Remember that as I said before, you also have some spindle cells here. Cat mast cells are very poorly granulated. I wouldn't expect to really see any granules in them. And a lot of times you have to do special stains to bring them out. Okay, this is a poor sample, but this is a vaccine-related sarcoma. The multinucleated cell is a macrophage, and the eosinophilic material within these cells is actually vaccine material. And you can see a neutrophil here, a couple of lymphocytes, and more spindle cells. The mass is on the dorsal lumbosacrum of a male dog, probably on the midline. We have clusters of neoplastic cells. Cells, even at this magnification, you can see that they are spaced out. Nuclei are very benign looking, okay? And you can see that these cells in the center have abundant cytoplasm around the edges. Little cytoplasm nuclei are similar, and this is that perianal gland adenoma that you can see. Well, this is a nodular mass from a dog. Site is somewhat immaterial. And this slide is an absolute mass. Okay? It's very blue. It's got keratin all over it. But the question to you is, what are these structures? And these will help you make the diagnosis. And then they really show up nicely in the areas where you have a lot of liquid. Those are cholesterol crystals. The aspirate was from an infundibular cyst, which explains all of the keratin and the mess and the fluid around it. But what locks in the diagnosis for us are these cholesterol crystals, which you will see with any keratin-producing cyst or neoplasm. Okay? Here's a male working dog. We are a similar aspirate. We have a lot of neutrophils. We have these polygonal, translucent blue squamous epithelial cells, and once again, these cholesterol clefts, cholesterol crystals. Apologize, I have cholesterol crystals. Okay, your interpretation? Well, there are a couple possibilities here. Okay, cholesterol crystals lead us to believe that we are looking at a keratin-producing cyst or neoplasm. It could be an infundibular cyst, as we just saw. It could be a follicular neoplasm, such as a infundibular keratinizing acanthomas, which is probably the most common, a trichoepithelioma or trichofolliculoma, or because of the neutrophils, we could even be dealing with a squamous cell carcinoma. Okay, but it's a nodular skin mass. Okay, so I tend to think that, and there's no evidence of malignancy here, no multinucleated cells, or anything like that. So I tend to put the squamous cell carcinoma way down on the list. This turned out to be an infundibular keratinizing acanthoma. What we saw were the neutrophils, likely from an area of rupture. One of the biggest problems with practitioners, and I am one myself from time to time, is whenever they see a nodular mass, they like to squeeze it and see what you can express from it. And what happens more often than not is you don't get much because you've squeezed all the keratin sideways into the tissue. Okay, and you're going to set up a really nice suppurative or pyogranulomatous response. So the inflammation, the neutrophils go very nicely with that keratin that we saw, and tells me that somehow some of this has been released into the surrounding tissue. As long as there's no release into the surrounding tissue, okay, there won't be any neutrophils.